and good afternoon, everyone. I appreciate everyone's interest in this topic, and it's certainly a pleasure to be able to talk to you this afternoon about ADHD in preschoolers. So before we get to your questions about that topic, I wanted to give you some background information in terms of what ADHD looks like in young children, diagnosis and assessment procedures that may be helpful for identifying young kids with ADHD, as well as talking about some of the challenges of diagnosis in this age group, and then finally focusing on treatment strategies that have been studied for this population. So, as a reminder, I'm sure all of you are fully aware of the diagnostic criteria for ADHD. And those same criteria, of course, apply for young children. And so we're looking at young children who have significant problems with inattention and or hyperactivity impulsivity. The interesting thing is that there have been a number of longitudinal studies that have been conducted over the past few decades that have followed young kids, 3 to 5-year-olds who have been identified with significant ADHD symptoms at that age, and then followed them longitudinally through elementary school, secondary school, and beyond. And it's pretty clear that the ADHD symptoms tend to be chronic for at least half of these young children, even going back to Susan Campbell's early work in the 1990s, and then more recently looking at some of the studies that John Levine and his colleagues have conducted, as well as Ben Leahy and his colleagues. And actually that number of 50% is quite a bit higher in more recent studies because those studies have really applied fairly stringent criteria in identifying young kids with ADHD. And it seems that if one does a thorough assessment and identifies ADHD in this age group, that chances are it's going to be chronic to some degree throughout the lifespan. So it's not something that they're going to outgrow for the most part. It is something that parents and teachers are going to have to support them with, over the long term. In terms of prevalence of ADHD in young kids, we don't have a lot of great data on that, but the data that are available would indicate that at least 2%, maybe upwards of 4% of 3 and 4-year-olds may be diagnosed with ADHD, and clearly there may be others in the community who are not being diagnosed at this point who do in fact have ADHD. So the prevalence figures are a little bit lower than the percentage that you see in elementary and secondary school, but not substantially lower. Again, it's roughly in that 2 to 5% range. The concerning point with regards to ADHD symptoms in young kids is that, similar to older children, these symptoms are associated with significant behavioral and academic impairment. The idea that ADHD symptoms in young kids may be benign or not all that debilitating has really not been borne out by empirical studies. In fact, it's the opposite. These are children who are, depending on the measure that you look at least 1 to maybe 2 standard deviations below their peers or behind their peers with regards to behavioral control as well as academic skills. And just to highlight 2 things here related to impairment. One is that some recent studies have shown that preschoolers and pre-kindergartners are at higher risk for being expelled from school settings than older kids. They don't have the same protections that elementary and secondary school students have with regards to expulsion, and as a result, the rates of expulsion are really sobering in the preschool population for kids with behavior difficulties, including ADHD. And I know in some of the research studies that we've conducted at Lehigh University, where I'm at, where we've recruited preschoolers into studies, I can't give you an exact percentage, but it's a much higher than percentage than you would be comfortable with of kids who have been expelled from more than one preschool. Even at age 4 and 5, they've been they're on to their 3rd or 4th preschool because of expulsions. So that's certainly an indicator of behavioral impairment. In terms of the academic domain, there's a number of studies that have shown that even upon kindergarten entry, young children with ADHD are already behind their peers with regards to both reading and math skills. If we go to the next slide. Thank you. For some reason, I'm not able to control the slide, so if you're able to do that for me, that would be great. In terms of diagnosis of ADHD in preschoolers, the diagnostic procedures are very similar to what is done for older children. And the primary methodologies include a diagnostic interview as well as rating scales that are completed by parents and teachers. And this is, very similar to what is done with older kids. In particular, with the diagnostic interview with parents, we're obviously focused on the DSM-5 criteria for ADHD, but also wanting to get information about possible comorbid disorders as well as disorders that could mimic ADHD. And in particular, two disorders that we pay a lot of attention to with this age group when we're interviewing parents is oppositional defiant disorder, or ODD, because there's a frequent overlap of ADHD and ODD in this age group in particular. In fact, we did a fairly large study of ADHD preschoolers a few years back, and we had 75% of our ADHD preschoolers also met criteria for ODD. So it's a frequent comorbid relationship there. The other disorder that we want to focus on with parents, given this age range, is autism spectrum disorders and developmental disorders, which could co-occur with ADHD, but also, more importantly, could mimic ADHD in terms of the concentration problems, impulsivity, and high activity level. So we want to make sure that we are, in fact, dealing with ADHD and not a developmental disorder or autism. Parent and teacher rating scales are a core component of the diagnostic workup, and we like to include both a broadband behavior measure like the BASC, the Behavior Assessment System for Children, and then more of a narrow band scale that focuses specifically on ADHD and externalizing disorders like the Conners. And similarly, that combination is useful for getting information from preschool teachers as well. And the nice thing about these particular measures is they have normative data for the preschool age group, which is critically important, as we'll talk about in a minute. If possible, we also try to get direct observations of child behavior, either in a clinic setting, under analog conditions, having them interact, for example, with their parents around both play tasks and, play activities and more structured activities or tasks, to look at the degree to which the child and parent get along with each other, but also the degree to which the child complies with parent requests and how the parent responds to child behavior in terms of positive reinforcement versus punishment. Also, direct observation of child behavior in preschool settings can be very informative in terms of some of those same issues, but also giving us kind of a local normative context for the child's behavior, where we can compare the child's attention activity level to their peers in the same preschool classroom to see the degree to which they stick out or are different from their peers. And this is particularly an issue where you might have a concern that the behavior difficulties are due to more of a chaotic preschool classroom environment where the teacher may not have full control of the classroom, or may have inconsistent management skills, and so you want to gauge the degree to which that may be playing a role in what might look like ADHD. And then finally, as I mentioned to you previously, we want to rule out developmental disorders, including autism, and that we would do through both the diagnostic interview with the parents as well as rating scales, relevant rating scales. So now, if we could go to the next slide, we can talk about the challenges that one might experience in terms of diagnosing this disorder in early childhood. And there are certainly a number of challenges here that need to be contended with. One fairly major one is that, as I'm sure you're all aware, the symptomatic behaviors that comprise ADHD, namely inattention, impulsivity, high activity level, pretty much describe every 3-year-old. If you just take it at face value, it's a description of childhood, early childhood. And so these are behaviors that are relatively common in home and preschool environments. So we need to make sure that we're accounting for that in the context of our diagnosis, as I'll talk about in a minute. The other thing that is challenging is the degree to which children's behavior at this age varies across time, across settings, across people who are taking care of them or working with them. There's just such high variability in their behavior that one needs to be careful that we're taking into account behavior over an extended period of time, and also looking at situational factors that might be accounting for the behavioral symptoms that don't necessarily represent ADHD, but may represent differences in management style or differences in the quality of the different environments. So those are two big challenges when we're looking at 3- and 4-year-olds in particular. So for that reason, it's really critical to establish several things. One is that we want to establish that the symptomatic behaviors of ADHD are happening at a really high frequency relative to age and gender norms. So this is where measures like the BASC or the Connors come into play, where one can look at scores on these measures relative to other 3-, 4-, and 5-year-old norms and identifying kids who are at the, beyond the 1.5 standard deviations or more above the mean in terms of these symptomatic behaviors. So that's key. And that gets at that issue of the symptomatic behaviors being relatively common. Secondly, we want to establish that the behavior is chronic. Now, the DSM-5 suggests 6 months. Well, it doesn't suggest 6 months. It requires 6 months. Others have suggested a longer period of time, particularly for preschoolers. So, for example, Russell Barkley and others have suggested that one needs to establish that the symptomatic behaviors are occurring for at least 1 year to really show that the behaviors are chronic and are happening, on a consistent basis over time. Thirdly, we need to establish that there's impairment, that it's not just the behaviors that are occurring, but also that there's some impact, particularly in terms of social or academic functioning. And so measures that tap into social skills and early reading and early math skills are going to be very important as part of the diagnostic workup in order to establish that there is impairment. And then finally, as I've mentioned several times, we need to rule out other hypotheses for the behavioral symptoms, in particular rule out the role that autism or other developmental delays or disorders might play. So then if we go to the next slide, we can talk briefly about treatment of ADHD in young children. And again, similar to the diagnostic protocol, the treatment procedures relative to ADHD in young children are fairly similar to the treatment approaches for older children and even adolescents, with, in particular, the two most strongly empirically supported interventions for ADHD being behavioral interventions implemented at home or school, and then psychotropic medication, in particular central nervous system stimulants. So just to briefly talk about each of those, the behavioral intervention piece, most of the research here with young kids is focused on parent education, family education in the use of behavioral procedures at home. And there's been a number of empirical studies that have supported this approach. For example, Carolyn Webster Stratton's work with the Incredible Years series, and there are others as well, but Webster Stratton's work in particular is notable here. And clearly that is a primary treatment approach for ADHD in young kids, and in fact, arguably it is the first line of treatment for ADHD in young kids, even before medication. In addition to the behavioral interventions, it's really important to work with parents and preschool teachers to support the development of early reading and math skills beyond what would typically already be in place for a young child. As I mentioned to you previously, these are kids that are at risk for coming into school behind their peers in academics, and so it's really important that those skills be supported. So, for example, strategies such as dialogic reading or embedded math instruction, where you're exposing children to mathematics principles through everyday activities, is really important. I want to make sure that I contrast that with a notion of extended drill and practice and forcing kids to practice skills at a high rate in this age group is really not developmentally appropriate, and also can backfire in the sense that kids could get really turned off to academic activities by being forced to drill and practice. What I'm talking about are more everyday embedded activities that include reading to children on a frequent basis, and then discussing math in the context of just everyday activities. Thirdly, it's really important to focus on injury prevention and safety promotion. Young kids with ADHD are at much higher risk than their peers for accidental injuries due to their high level of impulsivity and activity, higher rate of emergency room visits, higher rate of broken limbs, accidental poisonings, things along those lines. So it's really important that families act proactively to prevent injuries, to prevent accidental poisonings, and so forth. And then finally, psychotropic medication certainly can play a role, particularly for those with really severe symptoms. And the most famous work that's been done on this that you may be familiar with is called the PATS study, P-A-T-S, which stands for Preschool ADHD Treatment Study. It was conducted about 10 years ago or so now, the largest medication trial with young kids with ADHD. And the good news found that stimulants, primarily methylphenidate, reduced symptoms of ADHD both at home and preschool to a significant degree. So that's the good news. The not-so-good news was that the side effect frequency in this age group is higher than for older kids, and in particular there are concerns about growth inhibition, and the PAT study did show some reductions in the velocity of weight gain and height gain that would have been predicted without medication. And as a result, some of the families of kids in the PAT study itself, where there were positive effects with stimulants, despite that, they chose not to continue with medication following the research because of the concerns about side effects. And it's also important to note the American Academy of Pediatrics issued treatment guidelines for ADHD a few years ago, and they strongly recommend behavioral interventions, as we were talking about earlier, that those should precede medication use in this age group. So anyway, hopefully that gave you a quick rundown of some major concepts with regards to what ADHD looks like in young children, how we might go about diagnosing it, some of the challenges associated with that diagnosis, and then a general discussion of treatment strategies for ADHD in young kids.